Hello, everyone. My name is Dr. Yonit Arthur. I'm an audiologist and coach. You're on the Steady Coach. And today I'm going to be presenting a talk that I'm going to be giving at a conference this year. The talk is intended for healthcare professionals and other professionals who work with people suffering from neuroplastic or neural circuit disorders. And for those of you who are new here, these are medically unexplained syndromes that go by many names and produce many different kinds of symptoms, such as chronic dizziness, chronic visual symptoms, chronic pain, chronic tinnitus, chronic hyperacusis, and more. But because this talk is intended for professionals, it is highly technical and uses a ton of jargon and technical language that I don't normally use on my channel and may be hard to understand. So please rest assured you don't need to have FOMO if some of this talk doesn't make sense to you. I've already explained many of the components I'm talking about in this talk on my channel elsewhere. And I have upcoming videos that will translate this into actionable steps that you can take for your own recovery, just like I always do. That being said, I think it's important for this information to be publicly available to people so that as many people as possible have access to appropriate treatment for their neural circuit disorders. So please share this far and wide with whoever you think will benefit from it. And also, I'd appreciate it if you could also like the video and subscribe to my channel. This helps get the message out everywhere that it's needed. So, we are going to be talking today about multisensory neural circuit disorders, and I'm going to be presenting a unified framework for dizziness and other complex neural circuit disorders.
And then as soon as I started taking a few steps, my life completely changed. I felt like true vertigo symptoms of like spinning around. The world was feeling like it was an ocean. I was about to go to bed, and I remember felt like the bed was moving up like 8 to 10 feet in the air. I was terrified, just in a total fight or flight.
Yeah, I had lightheadedness initially, followed by heavy-headedness and sand feeling in the head. Then I had auditory hallucinations, and I had this extreme rocking sensation. I couldn't walk, I couldn't sit, and there was this feeling of intense doom. All I did in the first initial couple of months was lying down.
I would look around and people would walk past me and I could only see half of their face. My whole vision at one point was just black dots. My body was rocking up and down, swaying side to side, your head spinning, trying to sleep. And underneath it all was this sense of it was like impending doom.
Okay, so today we're going to be talking about disorders like these. And first, I'm going to be just giving you a baseline understanding of neuroplastic disorders that involve symptoms such as those described so beautifully by Alex, Dr. Uzma, and Rhea. But more ambitiously today, I'm going to be presenting a model that addresses a fundamental problem that all of us face in clinical practice: why some patients have a harder time recovering than others. I'm going to be presenting a unified model to first explain why multisensory neural circuit disorders are often harder to treat. But I'm going to apply it more broadly so it's immediately actionable to you in clinical practice, regardless of which symptoms you treat. So, multisensory neural circuit disorders are neuroplastic disorders that distort the perception of multiple primary senses. This includes most chronic vestibular disorders, including PPPD or persistent postural perceptual disorder, MdDS or mal de Debarquement syndrome, and vestibular migraine. And it's often misdiagnosed as chronic neuritis or uncompensated neuritis, Meniere's disease, chronic BPPV or benign paroxysmal positional vertigo, and cervicogenic dizziness. It also includes most medically unexplained POTS and dysautonomia, as well as most atypical or complex chronic migraine syndromes, involving multisensory distortion. And finally, it includes diagnoses like post-concussion syndrome, functional neurologic disorder, and visual snow syndrome. Okay, so as you heard in the brief vignettes I showed you, these patients describe a collapse of reality across multiple senses and typically have symptoms that span multiple categories. These include space and motion distortions such as dizziness, swaying, rocking, bobbing, and existential symptoms like anxiety, derealization, and dissociation. They also often have body and sensory distortions such as pain, proprioceptive changes, difficulties walking and moving. They will almost always have visual distortions, including blurring, visual snow, oscillopsia, palinopsia, and difficulties tracking. And finally, many of them will have auditory symptoms such as tinnitus, hyperacusis, and dysautonomia. Like other neuroplastic disorders, multisensory neural circuit disorder, or MNCD, is usually treated through an exclusively biomedical paradigm with limited success. These patients typically have no findings that explain their symptoms or normal abnormalities that don't explain chronic symptoms. And the same general pathway of central sensitization applies, which means that treatment involves reducing central sensitization. But there are some key differences, as I'm sure you observed in your work with your patients, especially those with symptoms like these. So, the first major difference is that these symptoms are, as I said, multisensory. These sufferers have many co occurring symptoms that affect multiple sensory systems and produce disorientation and disconnection from reality. They also often have accompanying physiologic anxiety, which you heard Alex, Dr. Uzma, and Rhea refer to as existential terror or doom. These symptoms themselves are inherently disorienting, hijacking the fight or flight system, and producing an extreme sense of dread and terror. This is not your typical obsessive or perfectionistic anxiety. There may be no psychological root cause. Unrelenting terror is a side effect of the symptoms themselves and will often be accompanied by obsessive compulsive type thought patterns and intrusive thoughts. And finally, multisensory perceptual and cognitive integration failures, producing dissociation and a disrupted sense of reality. Cognitive and alleged psychiatric symptoms such as brain fog, mental confusion, and cognitive difficulties also have a physiologic reason and are highly prevalent. Dizziness and dissociation, in particular, are often misinterpreted as mental illness by both patients themselves and well meaning healthcare providers. Patients themselves often question if they're going crazy. So, together, these features alter both recovery logistics because patients need direct guidance with intrusive thoughts, disorientation, and brain fog, and the underlying mechanics of persistence. Multisensory symptoms map onto the same general predictive processing model, but the way it plays out is altered. The mechanics are far more recursive, the system is less elastic, and symptoms feed back on themselves in ways that make recovery more complex. That's why treatment often has to look different. So let's back up first and talk about the mechanics. So, this is how I conceptualize neural circuit disorders. When the stress bucket fills with all different kinds of stress, overall threat load and uncertainty increase. This ultimately leads to danger mode, or a state of chronic threat appraisal that leads to chronic symptoms. This is true for all types of neural circuit syndromes, not just MNCD. Here's how it happens. The brain is a prediction machine, and to keep you safe, it needs reliable prediction maps. When a full stress bucket causes threat load and uncertainty to rise, the brain obviously needs to update its maps. First, many stressors create uncertainty. This leads to more prediction errors. The brain flags this and tries to update its maps. Second, other stressors reinforce existing threat priors or create new threat priors. This also increases threat prediction. Third, to manage either situation, the brain has to tighten lower level precision. It scans more carefully for signal, inadvertently raising the noise floor, causing innocuous signals such as normal sensations to be flagged as threat and to be made conscious. Fourth, this overload begins to produce bottlenecks. Map updating capacity is reduced, threat priors become sticky, known as a precision lock, and the brain ultimately locks into a chronic error state. This chronic error state becomes indistinguishable from external danger, which leads to chronic activation of the threat response system, even in the absence of external threat. Ultimately, this leads to chronic symptoms. But as we've already discussed, you've probably observed that not all your patients are the same, and not all their stress is the same. Some of your patients respond beautifully to education, and some of them seem endlessly stuck. In other words, some stress buckets drain easily, and others seem to be full of viscous material that is difficult to drain. That's where light, medium, and dense stressors come in. The bucket can fill up in different ways. Was it a series of life stressors that precipitated symptoms, or did they occur in the backdrop of profound childhood trauma? To simplify this, I characterize these stressors in these broad informal categories. Light stressors, the blue at the top, are situational stressors. These are work, stress, life events. These drain easily because they create the least uncertainty and threat. Medium stressors, that's the yellow, those I think of as stress fuel. These are things like perfectionism or chronic habitual suppression of emotions. These are somewhat sticky because they create more uncertainty and threat. And then finally, dense stressors, that's the red at the bottom. I think of these as pressure cooker type stressors. These are things like trauma and injurious core beliefs. These are viscous and hard to drain because they create the most uncertainty and threat. In short, the denser the stressors in the bucket, the more likely it is that threat will become the most statistically plausible prior. In other words, this means the system grows rigid, less able to discriminate signal, like actual danger, from noise, normal sensations, and less elastic. All of this ultimately means that the bucket cannot drain as easily. This is the key to understanding the real problem, how the bucket behaves in the real world when faced with new stress and treatment. The relative proportion of each type of stress, not just the total stress, determines what will happen. And that's where allostatic elasticity comes in. In the real world, new stress is constantly pouring into the bucket, and buckets create their own stress, which I'm calling recursive stress. For example, when someone's a perfectionist, this affects how new stress is perceived, say a work deadline, but it also creates its own stress where there wasn't any stress before, such as self imposed pressure to be perfect. When someone has an identity level belief like I'm not worthy, this affects how new stress is perceived, say an interpersonal conflict, but also creates its own stress where there wasn't any before. For example, constantly needing to people please. Symptoms are also a type of recursive stress, stress created by the system itself. So, in the bucket on the left, you can see there's a relatively high proportion of light stress. And so the filter on top doesn't increase the density of new or recursive stress. It can drain relatively easily. In contrast, in the bucket on the right, you can see there is a higher proportion of medium and dense stress. The filter on top of that bucket means that new and recursive stress become denser as they pass through the filter into the bucket because the filter reflects the contents of the bucket. What this means is that the bucket on the right fills itself with denser and denser stress over time. It becomes denser and more rigid. This bucket has a higher viscosity and lower elasticity. This means it cannot drain as easily. So, allostatic elasticity just describes what will happen in the real world to these different configurations of buckets. Put simply, it means how easily can your brain flex its maps and update its threat assessment when faced with new information like stress or treatment. In more technical terms, allostatic elasticity refers to the dynamic adaptability of predictive models governing threat appraisal, while allostatic load, or the types of stress in the bucket, reflects the cumulative physiologic cost of prior threat appraisals, which is a lagging indicator. Elasticity captures the system's real-time ability to revise threat predictions in response to new information. This is critical information for treatment. In high elasticity buckets, prediction errors drive constructive updating and stress drains. In low elasticity buckets, prediction errors are overweighted and noise is amplified. Stress compounds progressively into denser forms. The bucket is then harder to drain. So, allostatic elasticity is determined by the relative proportion of the types of stress in the bucket, and medium stress and dense stress are especially recursive. They don't just sit in the bucket and make it harder to drain. They convert new stress into denser forms that are also harder to drain. This is why two different people can experience the same neuroplastic disorder and have totally different outcomes in response to treatment. A high elasticity bucket easily drains, and a low elasticity bucket fills itself with denser and denser stress and becomes harder and harder to drain. This also explains why dizziness and multisensory symptoms can be harder to treat. Multisensory symptoms like dizziness, like visual snow, like all the other symptoms we talked about, are medium and dense stressors that recursively generate more errors and disproportionately quickly reduce allostatic elasticity due to the compounding effects of physiologic terror, disconnection from sensory reality, and cognitive symptoms. This explains why some of the techniques we are using, like cognitive behavioral techniques, don't always work with some of our more complex patients, and in particular, those with multisensory symptoms. At low elasticity, the mechanics are different, and treatment needs to be different too. Stages 1 through 4 depicted on this slide shows what happens as the relative proportion of medium and dense stress increases. These stages are defined not by symptom intensity, but by allostatic elasticity. how flexibly the system can reorganize when new information arrives. As elasticity declines, buckets dominated by medium and dense stress will convert new and recursive stress to denser stress that cannot be as easily drained, leading to even lower elasticity. Now let's take a closer look at these stages. On the bucket on the left, we're looking at stage 1. This is where light stress dominates. These are the patients who had just a deluge of life stress before symptom onset. These patients need reassurance, they need education, they need habit change and graded exposure. Why? Because we just need to reduce focus on symptoms and help them process or clear out new sources of stress, because there's just not a lot of self-generated stress here. These are people who you only need to see for a few sessions typically, or who have book cures. Now, stage 2 on the right is where most of our patients are. These are people whose buckets have a higher proportion of medium stress, which means these are your worriers and perfectionists whose responses are amplifying incoming stress. These folks need tools. They need graded exposure. They need somatic tracking. They need structured pain reprocessing therapy or emotional awareness and expression therapy. They do beautifully with journaling. They do well with self-compassion practices. They do wonderfully with cognitive reframing. Why? Because we're simply trying to reduce habitual stress amplification and increase allostatic elasticity, which in this particular case isn't that low to begin with. Things change in stages 3 and 4. In stages 3 and 4, the stress bucket is recursively generating stress, a lot of stress. The brain is in a chronic error state and it has low allostatic elasticity. Symptoms may not even be triggered. They may be 24/7, unrelenting, and extreme. Interoceptive maps are compromised. These patients may be totally shut down and in fusion with their symptoms, and even if they do seek your help, it may be without much hope of recovery. We're soon going to discuss interventions for these stages in more detail. But first, let's review common interventions that all of us are often using with these patients, and we're going to look at their relative effectiveness for the different stages. So, the first tool we often will go to is cognitive reframing, education to reframe symptoms as not dangerous. And in stage 1, the brain can integrate this information and reduce alarm. In stages 3 and 4, the brain can't integrate this information. Cognitive override of lower level precision locks is just not possible. And trying to explain it to them can increase confusion and alarm, especially if it doesn't make them feel better. This can increase symptoms. Somatic tracking. In stages 1 and 2, interoception is less globally compromised, so symptoms can be targeted and reinterpreted. In stages 3 and 4, interoceptive maps can be completely unreliable, tracking can be very difficult, and symptoms can be abstract and difficult to track. Graded exposure is non-negotiable for all stages, but it looks different in different stages. In stages 1 and 2, triggers are somewhat stable and have predictable patterns, so you can use them for diagnosis and for treatment and for tracking outcomes. In stages 3 and 4, triggers often change unpredictably, and when patients find that they're not really progressing from this kind of exposure, these dashed expectations often increase fear. Emotional awareness, also important for all stages. In stages 1 and 2, avoided emotions can usually be accessed and expressed, which reduces stress. But in stages 3 and 4, avoided emotions can often be tied to course safety priors. So that means they can't be accessed without a very high level of skill. Safety messaging. So essentially having patients tell themselves that they're safe either through cognitive means or somatic means. In stages 1 and 2, these messages land and can reduce fear. In stages 3 and 4, these can paradoxically create more fear because these clients literally never feel safe. They feel like they're lying to themselves when they tell themselves that they're safe. And furthermore, reassurance can reinforce threat priors. All of this to say, safety messages are often ineffective. Symptom reduction, which is the practice of waiting until symptoms are not extreme or engaging in avoidance behaviors or safety behaviors. This can increase safety in stages 1 and 2. Often in stages 3 and 4, symptoms are 24/7 extreme and unrelenting. So if we're waiting for symptoms to reduce, that can block progress. So, what does work in stages 3 and 4? Well, the framework of allostatic elasticity makes it clear what our interventions need to accomplish. The goals for stages 3 and 4 are to restore allostatic elasticity by loosening rigid priors and updating survival level predictions through experience. This enables the bucket to drain. So, first, here, symptoms are entry points to the very predictive maps that keep elasticity low. Don't dismiss them as errors or irrelevant. Patients' responses to symptoms point you directly to existing core beliefs. When you map the symptom to the emotion, to the predicted consequence or belief, that gets you to the origin story. And these are all pointing us directly to survival level maps that govern threat appraisal. These are the ones that we're going to be updating in the next step. Examples here. If I don't perform, I'll be abandoned. If I slow down, I'll be overtaken or irrelevant. If I let this feeling rise, I'll be overwhelmed or die. If I don't control this, I will spiral out of control. Again, these are all survival level maps. In doing so, we are reframing these sensations as messages, not errors. Reframing symptoms as diagnostic probes helps us know what maps need updates, but it also helps begin to change the patient's relationship to symptoms. Second, maps only change through experience, not through counteraction or talk. We want to follow memory reconsolidation conditions. Memory reconsolidation research defines a step-by-step process for updating predictive maps or schemas. We reactivate the target map, not just talk about it. We create a mismatch experience while the map is active, and we provide time and repetition for the update to stick. In the neuroplastic treatment world, we often default to counteractive techniques like thinking differently or habit change or having the person become more self-compassionate or self-talk. These do not usually update old maps. They just create competing ones. And our goal in stages 3 and 4 is to update survival level predictions. So if I don't perform, I'll be abandoned. If the patient is experiencing the full fear associated with that belief and the truth of that belief at the same time, while also having the juxtaposing experience of not being abandoned by you or family members, that updates the map. If I let this feeling rise, I'll be overwhelmed. When the patient is fully experiencing a feeling in its full intensity and at the same time experiences it as empowering or survivable, that updates the map. If I don't control this sensation, it'll spiral. Again, if the patient does not control the sensation and allows it to be there in its full intensity at the same time while experiencing that it is survivable, updates the map. These patients need to be shown, they need to experience this. We need to directly intervene in the predictive model, and the only way to do that is through imagery, movement, feeling, experiential work. This is how we update the encoded consequences of symptoms and other stressors. Now, third, pacing and exposure. We want to redefine what exposure means. Success in the situation of an exposure means self-relating differently. On a higher level, what you're teaching these patients isn't just, oh, you need to expose yourself to triggers to rewire your brain. It's demonstrating the experience of secure self-attachment, consistency, attunement, acceptance, reliability, repair of ruptures. When you start with a routine that's tailored for the worst days, plan a schedule as a baseline, setting the bar very, very low for some of these patients. This frames the purpose of these exposures as depending on reliability, not intensity. Reliability and consistency are enormous felt, experienced safety signals, not cognitive messages of safety that don't land with these patients. You may be using micro exposures with no performance requirement, where again, success means feeling fear while relating to it without trying to stop it via acceptance or allowing. Speaking of allowing, we want to replace reassurance with allowing. And that refers both to our tendency to reassure these patients, but also their habit of reassuring themselves. At low elasticity, reassurance can inadvertently entrench old models because it can provide proof that the threat is real. Allowing or acceptance teach the brain that this experience is actually survivable. Unconditional acceptance says this is okay even if it stays, while also knowing ultimately that this rewires circuits related to symptoms. And finally, we need to expand the bucket, not as a fix, but to restore baseline capacity. Baseline capacity for stages 3 and 4 is already so low, so lifestyle and stress reduction is much more important for these patients. Exercise, sunlight, fresh air, good nutrition, these are essential for these patients. So if you want to know more about what recovery looks like for MNCD, you should definitely take a look at the success stories I'm highlighting on this slide, Sam M. and Vanessa W. And there are some additional resources, of course, on my website, the free course, on the YouTube channel. And I'm working on an upcoming course for providers to teach people how I work with these particular clients. Thank you all so much for being here, and a special thank you to Sam, Spencer, and Dan for your contributions to this presentation. I appreciate all of you tuning in. And if you're here on YouTube, again, I hope this presentation was informative and helpful to you, and I'm looking forward to hearing your questions and comments below. Please like, share, and of course, as always, subscribe to my channel, and I will see all of you very soon. Take care.